behalf of GI Hepatobiliary Division of Max Institute of Cancer Care for this academic session. So, as you all know, we are running this webisode, a purely academic event for students of GI surgical oncology, GI surgery, and medical and radiation oncology students. And we have reached so far in gallbladder cancers. So currently the topic is running on gallbladder cancers. We have covered pancreatic, esophagus, hepatocellular cancers, NETs, and GIST. So in gallbladder cancer, we have so far covered the basic overview and approach. And now we have reached to the multimodality approach towards GB carcinomas. So in today's session, we'll be covering this multimodality approach, and the format will be same as lecture followed by a panel discussion. So I invite Dr. Mahesh Goel, sir, who is professor and head of the department surgical oncology in Tata Memorial Institute, Mumbai. And sir will be delivering a lecture on the multimodality approach towards gallbladder carcinomas management. Sir, I hand over the stage to you. Please take over.
Thank you, Shefali. I will need to share my screen. So,
Ji, sir. Yeah. So, Shubham, please hand over the sharing rights to sir.
You can go ahead, sir. You can share it. You have the right.
Okay, just complete. Has to come down. Yeah. Now, share screen. Is it visible?
Not yet, sir. Yeah, now it is visible.
Okay, so now.
Right, sir. Please make it full screen, yeah. Sir. Yeah, thank you, sir. Yes.
So thank you for inviting me. Only thing is, I am little bit under the weather, so I might need to interrupt myself 2-3 times in between before I can actually complete the talk. So just bear with me. So coming to
no worries, sir. Yeah.
So coming to multimodality treatment of gallbladder cancer. So let me first take you through how the treatment for gallbladder cancer has evolved. So what are the treatment challenges for gallbladder cancer, especially in a country like India? So we are a low resource endemic areas for gallbladder cancer. And if you really look at treatment differences, there's a huge amount of difference in the way gallbladder is treated between east of the world and even west side of the world with respect to staging, treatment, survival. Till now, there is no level 1 evidence that this is how the gallbladder cancer should be treated. And most of the guidelines are actually represents individual institutional practices. So even today, the world literature on treatment is really very sparse, and most of the treatment strategies guidelines are extrapolated from studies where cholangiocarcinoma is combined with gallbladder cancer. So having said that, till now there is no high quality data actually even on chemotherapy or chemoradiation for gallbladder cancer in neoadjuvant setting. But having said that, surgery still remains the treatment of choice for gallbladder cancer. So if we really look at how the treatment of gallbladder cancer has evolved, surgery was first described way back in 1780s actually. But till Alfred Blacklock in 1924 said that where a diagnosis of gallbladder cancer is where no operation should be performed. From such a dismal situation, we have progressed in surgery to the area, to the what is the current surgery practiced. I can't even see my myself. Yeah. Modified by Glenn's operation, where we do a block resection of gallbladder with GP fossa or segment 4B and 5. Then that's again a controversy which needs to be addressed with regional lymph node dissection. Okay, so but what is the outcome with surgery alone in gallbladder cancer? 2 large registries, one from Japan, one from Korea, have shown with large number of patients, more than 2,000 patients in each of the registry that the outcome, the 5-year survival for stage 3 cancer did not improve beyond 30 to 40%. With best of surgery, most radical of surgery, we could not go beyond 30 to 40% for stage 3 gallbladder cancer. So where is the glitch? So that is because gallbladder cancer is a very aggressive tumor. And if we really look at patterns of failure in gallbladder cancer, compared to even intrahepatic cholangiocarcinoma, the distant failure rates are upwards of 85% for gallbladder cancer. This is from MSKCC data. We looked at our own data from Tata Hospital of more than 500 resections. That is when we published. And we found that 73.5% patient failed at distant sites in gallbladder cancer. And the distance recurrence was mainly seen in patients with more advanced disease, which would be probably stage 3 disease and above. So this prompted us to look beyond surgery, because surgery alone has been unable to improve outcomes, though surgery has been practiced the way it is in last 20-25 years. But we failed to improve the outcomes beyond probably 30 to 40% 5-year survival with surgery alone. So there was a need to look beyond surgery. And that is when we started looking at multimodal approach or multidisciplinary treatment approach, not only treatment alone, but even diagnostic approach to improve survival especially in stage 3 gallbladder cancer. So if we really look at gallbladder cancer, we are not really looking at early gallbladder cancer, which would be probably stage 0 or stage 1A, where surgery alone gives you a survival benefit of almost 5-year survival, upwards of 90-95%. I will not be talking about metastatic gallbladder cancer, because whatever we do, the outcomes are pretty dismal. Hardly any patient will have a survival beyond a year for metastatic gallbladder cancer. So where can we improve the survival in gallbladder cancer? That would be 2 regions. One would be what we have defined and labeled as locally advanced gallbladder cancer. I'll come to that. That would be a stage 3 gallbladder cancer, and also in the incidental gallbladder cancer. These are the 2 places where probably multimodal treatment is making a difference in improving outcomes. So we also introduced the concept of high-risk gallbladder cancer in our paper, which I'll discuss in some time, mainly because we recognize that gallbladder cancer is a aggressive tumor with very high incidence of micrometastatic disease, early hematogenous and lymphatic spread, and if we can select a tumor out of these gallbladder cancer, if we can select tumor with favorable biology, that will ultimately determine the outcome for this group of patients. Because early progression on probably neoadjuvant therapy would spare these patients morbidity of a major hepatobiliary surgery. So we defined high-risk gallbladder patients as patients at high risk of failure post-surgery, either distant or loco-regional. So it was just prudent that in these patients, it would be worthwhile to initiate chemotherapy early, which became our concept of perioperative therapy, with possible clinical benefits being natural selection of tumor with less aggressive behavior, which would do well after surgery, increasing the R0 resection rate, which will also again reflect in increasing overall survival, and of course, downsizing the tumor with improved resectability with lesser magnitude of surgery. So when we started our whole process of this multimodal treatment or neoadjuvant treatment, first paper we published was in 2015, where we looked at, it was initially a pilot study, where we looked at neoadjuvant chemotherapy, and we found that their overall response rate was almost 67%, and almost 50% of these patients underwent R0 resection, which improved their overall survival to almost 14 months. We also looked at radiotherapy. So during the same time, I think this is the AIIMS group, which also published a similar paper of their experience with neoadjuvant chemotherapy and showed that NACT improved resectability. We also looked at neoadjuvant chemoradiation for locally advanced gallbladder cancer. So this was again a pilot study which we got published in Annals in 2016, where we showed that patient who could complete planned chemo radiation did much better in terms of survival. However, our morbidity with this group of patients are high, and we needed to modify our radiation dose, which we had done in our current ongoing trial on of Polka GP. Will again, I'll come in some time. So this was our first main paper which we published, emphasizing the role of multimodal treatment in gallbladder cancer. We looked at our own data at that time of more than 500 resections where we had done multimodal treatment in terms of initiating neoadjuvant chemotherapy followed by adjuvant chemotherapy. And we found that surgery alone was curative only in early stage gallbladder cancer, which would be stage 1. And as the stage improved, the systemic nature of gallbladder cancer became more and more evident. So we concluded, and the nodal positivity and stage was the main factor affecting long-term survival. So we concluded that multimodal treatment may actually add meaningful survival to gallbladder cancer with inherently aggressive tumor biology. And we actually, in this whole study, we showed that the estimated 3-year survival could be pushed up to almost 60% with introduction of neoadjuvant chemotherapy followed by adjuvant chemotherapy, that is perioperative treatment. This was the paper where we actually defined the criteria for what we called as the locally advanced or borderline resectable gallbladder cancer. So any tumor, the criteria we bordered almost on the same criteria as initially borderline resectable pancreatic cancer. So T stage more than T3 or T4, where the liver is involved or a contiguous organ is involved, or you have obstructive jaundice. Nodal station based on radiological criteria of suspicious lymph node metastasis, any involvement of vascular structure going to the liver, and also for incidental gallbladder cancer, where if a patient presented after index surgery and you find that there is either a residual or recurrent mass in gallbladder fossa or a node, we implied either the patient stage, initially stage of surgery was much higher for a surgeon to leave behind disease, or the disease has already come back too fast in the post-operative period. So those patients, we club them together and label them as high-risk gallbladder cancer, which are likely to fail. And these were the patients where we thought introducing chemotherapy would help us in improving the outcomes. And we actually showed in this paper that patient who received neoadjuvant chemotherapy and underwent surgery and went on to complete their chemotherapy had a superior statistical overall survival, much more 25 months versus 5 months, which was statistically significant. And if we looked at, and during the same time, even paper coming out from MSKCC also stressed the fact that locally advanced or lymph node positive gallbladder cancer, definite resection is possible in a subset of these patients who are selected for surgery after a favorable response to chemotherapy. So even in the West, people had started thinking about introducing chemotherapy to initiate chemotherapy to downsize or downregulate gallbladder cancer before offering surgery as a curative option. Krish Menon published his systematic review in 2018 in EJSO, where he also looked at all the previous studies where they have looked at chemotherapy or perioperative therapy, and concluded that there is still insufficient data to support the routine use of NACT or NART in advanced gallbladder cancer. But further studies in the form of RCTs are required to investigate the role of neoadjuvant therapy in advanced gallbladder cancer. This is the trial which we are running at present in our center. Hopefully, this will answer the question about perioperative therapy in terms of either neoadjuvant chemo or chemotherapy, chemoradiation, followed by surgery. So as we select patient as per our locally advanced gallbladder cancer criteria, so all of them will be T3, T4 tumor and node positive patients. So they are randomized to 2 arms. One is NACT arm, one is NACT-RT arm, and after that they are subjected to surgery after 3 to 4 weeks of NACT or NACT-RT and followed by adjuvant chemotherapy. Hopefully this will provide us some information on the exact way to go in terms of multimodal treatment. So coming to adjuvant treatment for gallbladder cancer, again, as I said before, there is still now no RCT to off on which will define adjuvant treatment for gallbladder cancer. Most of this has been extrapolated for success in either advanced disease, metastatic disease, or of biliary tract cancer, which would mainly from West contain more of cholangiocarcinoma patient than gallbladder cancer. First was the study which published in New England Journal of Medicine of GEMSIS for, it was mainly for metastatic, so gallbladder cancer adjuvant treatment was extrapolated from here, and the SOC trial again from America looked at concurrent CTRT. Meta-analysis published in Cancer in 2015 looked at the studies published at that time, and they showed that there was no significant improvement in overall survival with adjuvant treatment with radiation, but with chemotherapy as adjuvant treatment, there was significant improvement in survival, especially in node positive, non-stage 1 disease, that is either stage 2 and above, and margin positive patients. So again, a court study, randomized phase 3 study did not show much difference in adjuvant treatment, but it tended to move towards adjuvant treatment for gallbladder cancer. As also the randomized trial published from the BCAT study group of Japan, where they showed that adjuvant did not have much of benefit for biliary tract cancer, but it definitely showed a benefit in gallbladder cancer patient. The landmark trial, which everybody keeps talking about, the BILCAP study, again had only 18% of patients which were gallbladder cancer, and they showed that capecitabine did improve survival, and they wanted this to become a standard of care for adjuvant in gallbladder cancer. We published our own data on adjuvant chemotherapy for stage 3 and 2 gallbladder cancer, and showed that with the completion rate of 80%, we showed that the median follow-up of the 3 year is recurrence-free survival are upwards of 60%. And this is what we advocate and what we are using now at our center. But of course, we need to have further evidence, which is awaited, which hopefully will come from our trial, Actica trial, and another GB-GCOS study, which we are doing at Tata Hospital. So to summarize, if we really look at multimodal treatment for gallbladder cancer, as I said before, for early stage cancer, stage 1A, stage 0, stage 1 is simple cholecystectomy is curative. There's no need of revision surgery or lymphadenectomy, since the risk of lymph nodal metastasis is less than 5%. But of course, we need to define treatment strategy for gallbladder cancer encountered in an unsuspected case of laparoscopic or open cholecystectomy. So I would say that if you have a facility to do frozen section 1, and you have also the expertise to do extended surgery or advanced surgery, you can go ahead, subject that suspected gallbladder sample to a frozen section and complete radical cholecystectomy if you have the expertise. If you lack one frozen section or the expertise, then it is prudent to just close the patient and refer to a center which is qualified to treat these type of cancers. So for stage early cure, or what we call as early gallbladder cancer, which I would probably, or operable, I like to call them as operable gallbladder cancer, stage 1B, stage 2, and very selected stage 3A, like you see a mass in the gallbladder, probably just going out of gallbladder, involving a little bit of, we should make it early T3 and 0 type. Radical cholecystectomy is the treatment of choice. However, all these patients should receive adjuvant chemotherapy as a standard of care, which is now also being propagated in NCCN guidelines. Radiotherapy should be reserved only for margin positive resection, which would be in all probability at the cystic duct margin. And as I said before, GEMSIS as adjuvant chemotherapy is the way forward for us now, though we are again looking at our trial where we are comparing capecitabine versus GEMSIS. So another important topic is incidental gallbladder cancer. I would not go into detail, but this is how we do manage incidental gallbladder cancer. Whenever a patient of incidental gallbladder cancer comes to us after index surgery done outside, we restage the disease always. If the patient comes too early to us within 2 to 3 weeks, we would restage by CT scan. If it comes after 4 weeks, we will restage by doing a PET scan. And we have reasons for that because we have seen if we do a PET scan in this group of patients, almost 40% will get upstage actually. So if there is no disease on restaging and the original histopathology showed it to be T1B and above, we would do revision surgery immediately, which would be a revision radical cholecystectomy. However, if on restaging we find some disease in the local area or a node which is suspicious and no other disease on PET scan also, no non-metastatic disease, we'll treat it as locally advanced gallbladder cancer, where we'll subject this patient to neoadjuvant chemotherapy first and then take up for surgery after 3 to 4 cycles. The surgery essentially remains same, but it is important to revise the cystiduct stump to confirm margin negativity in frozen section. EHBT can be performed, but only for complete nodal clearance if the nodes are densely adherent to bile duct, or if you are not able to achieve a negative margin on the cystic duct. There is no role of routine excision of port site or scars or extrahepatic biliary tree in revision surgery. As far as timing for revision surgery go, we have recently published a paper on incidental gallbladder cancer, where we have shown there is no upper or lower limit for revision for surgery and should be done as early as possible and wherever feasible. And for where we have also shown, this is the paper which got published in Annals just now last year, where we have shown that revision surgery is at best the most accurate staging procedure with prognostic implication. It's not the surgery alone which improves survival. Actually, surgery just helps you in exactly staging the disease at that point of time so that you can initiate systemic therapy, and which is the key for improving survival in this group of patients. Another group of patients where multimodal treatment actually works is, this is a paper published this year only, where we looked at patients who present with obstructive jaundice. A lot of work has been done or published in, Dr. Aggarwal has also published on obstructive jaundice in gallbladder cancer. These are our analysis of 113 cases, which is probably the biggest series of obstructive jaundice in gallbladder cancer. What we realized that we could group patients into 3 groups. One was where the gallbladder cancer was incidental along with a benign biliary pathology leading to obstructive jaundice, which could be either choledocholithiasis or a stricture. The second group of patient was patient with nodal compression, and third was patient with isolated bile duct infiltration. So when we looked at these group of patients, we realized that gallbladder neck was the commonest site of malignancy accounting for obstructive jaundice, and patient where we could drain the jaundice, give neoadjuvant chemotherapy, because understand if whenever a patient with either nodal compression or bile duct infiltration comes in, leads to obstructive jaundice, this means that this is a T3 plus disease or N plus disease, which would qualify it to be a locally advanced gallbladder cancer. So any patient who after draining jaundice completed neoadjuvant therapy and surgery had a 5-year survival of upwards of 45%, which was equivalent to any cancer of the equivalent stage, which was not jaundice. And obviously, this was expected that direct bile duct infiltration group fared best, mainly because the nodal patient with nodal compression would always have a nodal metastasis, and node positivity is a very bad prognostic factor. So just to end this, the take-home message would be that we should understand that gallbladder cancer is an inherently aggressive cancer with very aggressive tumor biology. Surgery still remains the standard of care, but we should understand that surgery alone is not going to take us too far, because failures are mainly distant, and we need to do something more to control this distant failure, which has led us to introduce the concept of neoadjuvant treatment in terms of neoadjuvant chemotherapy, which is becoming more and more popular now. And yes, adjuvant chemotherapy in all P, T2 and above or node positive disease. Molecular targets are getting developed and will probably add to precision-based therapy in the future, but definitely time to look beyond surgery for gallbladder cancer. So thank you for a kind patient hearing.
Yeah, thank you so much, sir, for a very crisp and summarizing talk. So I think there are two questions in the chat box. First, so you have already answered in your talk. So Dr. Roshni asked, which of the incidentally detected gallbladder cancer should be subjected for immediate redo surgery? And what is the time frame when such surgery may benefit? So I think you have already answered, sir. The second question is, do you think that histology in these cancer matters? So she has asked, what about poorly differentiated tumors and revision surgery? So does histology matters in deciding neoadjuvant?
So I would say no, probably it's the histology is not shown to have benefit in terms of improving outcomes. It is always, of course, if it's an aggressive histology like a poorly differentiated, the chances that patient will have nodal metastasis would definitely increase. So it is mainly about node positive. Node is the strongest factor actually, as well as the T stage, not so much as histology. If on restaging we find that patient is still non-metastatic, we will treat it as per the merits of the T and N stage rather than the histology per se.
Right, sir. Right. So thank you so much, sir. And we request you
Dr.
to
Shefali,
stay back. Yeah, Dr. Nikhil, please.
Yeah, hi, sir. It was an excellent talk. We learned a lot. And in fact, TMH has been a pioneer in introducing some of the new adjuvant classifications and sort of borderline resectable as in pancreatic cancer. So I've looked into that paper, I've read that paper, and we also follow it somewhat. A couple of questions from that paper specifically when it talks about new adjuvant. So sir, like, do you do EUSFNA, or if the imaging shows a lymph node, you would consider it as positive and put the patient on new adjuvant?
So the thing is USFNA is an expensive procedure. So I don't think it is easy for us to get that into guidelines. So we actually go by radiological criteria only of heterogeneity of the node, the axis of the node, and we assume. And most of these LAGBC, we also get a PET scan done. So we combine these radiological criteria to define whether the node is positive or no. Any doubtful node where we have to, the decision would change. So for example, if you have a pre-cable node, which could be station 13 or a pre-cable or a para-aortic station 16 node, which may or may not be positive. So in that case, instead of opening up the patient, we would probably do a CT guided FNA of that node. So US FNA, one thing is very operator dependent. We don't have expertise as of now everywhere, and it is very expensive. So we do not recommend that as of now.
And the similar question in case of incidental. So, I mean, in a known case of gallbladder cancer, if there is a radiologically positive node with the limitations of US, which you are alluding to, I think that's a fair point where we can take them as positive and put them on neoadjuvant, but especially in the context of incidental CAGB, where a post-operative bed could cause some of the nodal enlargement. So how do you take such cases?
Okay, so in such a case, so if we have a previous proven histology, so if it is T2 and above, so we'll have two scenarios. Let's have one patient who is T1B on the previous histology and one is T2 and above. So we know T2 and above will anyway need adjuvant chemotherapy. So it is best for us to test chemotherapy initially or initiate chemotherapy since primary surgery is already done, even the nodal sampling is not done. So, so in such cases, probably we'll give 2-3 cycles of chemotherapy just for the point of view that we initiate chemotherapy, which helps in improving outcome, and then go in and operate. T1B, where we know chemotherapy, we will not give, it turns out to be node negative. So in these cases, we will be inclined to go in immediately for surgery and then harvest the nodes and see whether they are really positive or no, because that is going to decide whether a patient will receive adjuvant chemotherapy or not.
Right. So basically you would err on the side of giving chemotherapy.
Yes.
Right, sir. And what I find that table is silent on bile spill.
Yes.
So if the patient or rather the surgeon or the operative notes give you history of bile spill,
Yes.
how would you proceed in such cases?
So bile spill we would take as a actually metastatic disease probably, because it is very difficult to define. No surgeon really would write, even if you have, very rarely you will get a notes which will specify that biliary spillages occurred or the gallbladder got punctured or whether they removed the gallbladder in a bag or no. But a documented bile spill, we would address, subject the patient to chemotherapy first, assuming that bile spillage has occurred which would upstage the disease. We'll give chemotherapy and see the response. It is again about testing the tumor biology. If the patient does not progress, remains stable, then we would err on the side of going in and doing a curative resection for a patient who has had a bile spill, which was probably localized, but the systemic therapy took care of any potential metastasis which could have occurred. We also give the patient time and the tumor to select the tumor biology of this patient, but then we will go in.
Fair point,
Sir, one more question. Do you believe in oligometastatic concept in case of GB or hepatobiliary?
Yeah.
And especially synchronous or metachronous. When I say synchronous, means you open up and if there is a single omental deposit or a localized one at that area, or if a oligorecurrence, say DFI is good. So do you believe in that concept in GB
We
and
are in the
GB?
process of actually, or we are almost written up that paper. We were in the process of that. So one paper we published on port site metastasis. So we definitely believe in this concept of oligometastatic state. So though we believe that port site metastasis is a systemic disease, we looked at our own data. We also published. So isolated, sometimes we do get a patient who has just one single isolated port site met. So in such a patient, we again test tumor biology by first initiating chemotherapy, and we find that the disease does not come anywhere else. Then we have gone ahead and resected that port site metastasis, and patients have done well, which we have already published. We are also looking at oligometastatic state for our patient. I mean, we had 2-3 situations where we have opened, found a parayotic lymph node positive, no other metastatic disease, where we have closed the patient. And we had actually opened, frozen did not report a positive node at that point in parayotic, and final histopathology showed a positive parayotic node. Or patients where you have a discontiguous met in liver, but it did come within the wedge of the segment 4B5 excision. But it was definitely discontiguous, but resectable. And these patients actually have done well, much better than a standard stage 4 disease where no surgery has been done. We are in the process of analyzing data. Probably, hopefully, will come out with a paper on that, where the concept of oligometastatic gallbladder cancer would be looked at differently. I mean, it's like all other malignancy where oligometastatic state is now looked at differently, especially even in gastric cancer or in breast cancer. So we probably are coming to that area where we look at it differently now.
Right. And what is the time frame of chemo, sir?
Dr. Shefali, I want a little more clarification here. Because see, when we talk about oligometastatic, generally we talk about a pure metastatic disease, like it has gone to liver or lung. So the cases which you said, like port site metastasis, is generally we consider this as an implantation metastasis.
That is different, yes.
Right. And segment 4B5 also you can sort of consider as the local spread. So only like the concepts she was alluding to, probably these cases or the examples which you gave doesn't fall into the groups which she wanted to specifically ask.
No, port site is different totally. So oligometa, so that's why, I mean, we are a little bit conservative. I mean, frankly, till now, our concept is that if you have a distant met, even if a single met, we back out. So that's why we till now have no data per se on really oligometastatic disease, if you talk in that term. So we just coming closer to that. So that's why I said probably a parayotic node, which was reported later on as positive, and we went ahead and did a radical resection in that. Discontiguous liver met, even if you really go by term of liver metastasis, if it is not, it's a discontiguous met, then it is definitely a liver met which is distant met, counted at distant met. So we are looking at those patients only at the moment, but that would be a step forward towards looking at oligometastatic. We don't, right till now we have no exact data on oligometastatic, but probably we may be, as I said, we may be moving forwards towards that process where we may define oligometastatic disease and treatment for gallbladder cancer in future, not now.
Right, sir. And what is the time frame of chemotherapy to select biology? Is it 3 months, 6 months, or how do you go about it?
So we generally assess after 3 to 4 cycles to see whether the patient is responding or not responding to chemotherapy, whether the disease is stable or progression has taken place. Generally, for a metastatic disease or for a purely locally advanced disease which are totally unresectable at present, we would complete 6 cycles of chemotherapy and do, but like any other disease, look for maximum response. Probably anywhere somewhere down the line between 3 to 4 cycles also patient becomes resectable, we would go ahead and resect.
Right, sir. Thank you so much, sir. Dr. Nikhil, is there any other question?
No, there are no more questions, and I guess we can thank sir for an excellent talk. And
Absolutely.
With this, I would request Dr. Sandeep Batra. Hi.
Hi, Dr. Nikhil. Hi, Dr. Shivali.
Anji, welcome.
Good evening, Mahesh sir.
Good evening.
So, Dr. Sandeep, please, panel discussion.
Yes, sure, I will do that.
So, sir, Dr. Sandeep, would you introduce the panel or should I do that?
If you could do the honors, I will set up my slides in the meanwhile.
Sure, Ji, sure. So, I welcome all the eminent panelists. So, we have Dr. Mahesh Goel, sir, who will be joining as a panelist also. And we have Dr. Pooja Nandwani, who is Senior Consultant and Head Department of Radiation Oncology in Sterling Cancer Hospital, Ahmedabad. Welcome, ma'am. We have Dr. Sumant Gupta, who is Senior Medical Oncologist in Sarvodaya Hospital. Welcome, Dr. Sumant. We have Dr. Bramhadatta Pattnaik, who is a Senior Hepatobiliary Surgeon in ILBS Hospital. Welcome. Welcome, Dr. Pattnaik. And Dr. Abhishek Aggarwal, who is Consultant Surgical Oncology in Rajiv Gandhi Cancer Institute. Welcome, Dr. Abhishek. And Dr. Atul Sharma, who is Consultant Medical Oncology in Indraprastha Apollo Hospital. Welcome, Dr. Atul. So I welcome you all for the panel discussion. And Dr. Batra, who is Director Medical Oncology, Max Cancer Institute, Saket. So he will be moderating the session. Welcome to you, sir, also. Please take over for a panel discussion.
Thank you and good evening, everyone. Yeah, thank you, Shefali. Thank you, Nikhil. And welcome and good evening, everyone. Though my panel discussion is regarding the multimodal treatment, but after Mahesh sir's lucid talk, I don't think there is any doubt remaining about what should be the multimodal treatment like. However, since it was a dialogue, I would like to constitute a multi-log by involvement of all of us so as to further clarify their doubts, their gray zones in the management of the gallbladder cancer. And I know there is no category one evidence or good evidence for actual or appropriate management, but the evidence keeps on coming and the practices keep on refining. So there are only 3 ways the gallbladder cancer is diagnosed. If it is a preoperative diagnosis, it's an intraoperative diagnosis, which is incidental, and a post-operative diagnosis, again an incidental. So I would like to ask right from the surgeons. So I start with Dr. Mahesh Goel, sir. So what is the incidence of preoperative versus intra or post-operative gallbladder cancer? So indirectly, I'm trying to ask, how many of us get the shock of getting a gallbladder cancer if we are operating? And consider this question as a general surgeon, not as an oncosurgeon. So Mahesh sir, how many gallbladder cancers you see they were preoperatively diagnosed versus intra or post-operatively diagnosed?
Okay, so I will tell you, we looked at our patients who were referred to us as gallbladder cancer. So of being a cancer hospital, we assumed all the patients with primary gallbladder mass referred to us would be gallbladder cancer. But when we looked at our data, we realized that 50% of those patients which we operated actually turned out to be benign. So they were either chronic cholecystitis, large group of them was xanthogranulomatous cholecystitis, and there is no way where you can differentiate a xantho from a gallbladder cancer. which can mimic gallbladder cancer in any way by even causing a biliary obstruction, a mass effect, or infiltration onto the liver parenchyma also. So it is in early gallbladder cancer, yes, if you're doing a lap chole with the intraluminal mass, it is almost impossible to make out. That would be truly incidental. So in the definition of incidental also has changed. So incidental is now considered a tumor which is not suspected as gallbladder cancer at all when the surgeon is operating. And it is a pure histopathological surprise. But having said that, it is really difficult to make out. So almost 50% of gallbladder cancer or a chronic cholecystitis xantho may turn out to be positive or negative.
Okay, so Dr. Atul sir and Dr. Abhishek, any viewpoints upon that preoperative versus real incidental gallbladder cancers?
Hello, sir. I think a fair number of patients we do receive after having surgery done somewhere outside and not suspected gallbladder cancer. Around 20 to 30%. Still, we get patients who are operated outside and then found out to have.
You are fairly matching with the figures that we have analyzed at our institute. 20% is the percentage who are real incidental diagnosis. And in about 80%, I'm leaving aside the benign ones. 80% were diagnosed preoperatively because the investigations done, because the patients became symptomatic, and hardly less than 20% patients of gallbladder cancer who become symptomatic are not diagnosed as gallbladder cancer to start with. So having settled that question, now, there was a very detailed discussion by Dr. Mahesh regarding the neoadjuvant treatment, and there were some criteria. There are criteria from TMS, there are criteria from MSK regarding who are the patients who can be considered for neoadjuvant therapy versus who should be upfront operated. So these all trials have already been alluded to by Dr. Mahesh sir. So let's start from, I think, from the medical oncology side. How many of you are currently practicing neoadjuvant therapy? I'm saying therapy, not chemotherapy or chemoradiotherapy. We'll be coming to that question. Neoadjuvant treatment in a confirmed gallbladder cancer patient. How many of you are actually practicing? And I start with Dr. Pooja. Do you really practice this in your clinical practice, or you're still going to adopt this practice in future?
So honestly speaking, as of now, we are not practicing the neoadjuvant approach.
Okay, Dr. Sumant.
Sir, I don't think I have not yet started practicing. So,
Shefali, though you are not part of the panel, but this is one question I would like to ask, because even I have not started using neoadjuvant chemotherapy in gallbladder cancer patients as on today.
Correct. So in a resectable gallbladder cancer, we are not doing it as a neoadjuvant approach in high risk even. Yeah.
Okay, Dr. Bramhadatta. We have Dr. Bramhadatta in the panel.
So only a few cases I would mention, like incidentally found gallbladder where completion surgery is not done and you do a scan finding a heavy nodal burden. Or
no, we will be coming to that. We will be. It's a confirmed.
It's a neoadjuvant or it's a perforated. So
okay.
that is the only scenario I think we are not doing it in a resectable. Yeah.
Yeah, or sometimes, sir, the scenario is like the incidental case where the patient doesn't want a resurgery or there's a time to resurgery. He wants a break. That might be a scenario where you give a neoadjuvant, a CTRT or neoadjuvant surgery where you want to take a break for the second surgery or a completion surgery.
So I would say as an individualization, we might be using in our practice, but as a standard of care, I think neoadjuvant chemotherapy is still to come into our practice. Mahesh sir, what is the approach at TMH? You showed data from your patients. Yeah. So are you routinely inculcating neoadjuvant therapy in your patients with a advanced T stage or advanced nodal burden, though known metastatic nodal burden?
So we have to understand one thing. So if you look at data, the stage 3 gallbladder cancer, stage 3 would mean T3, T4 and N+ disease. The survival is with surgery alone is not more than 30 to 40%. One. Secondly, the failure rate, if you look at all the published literature, the distant failure rate is upward of 60 to 70%. So going by cancer sense, I mean treatment sense, if you really look at, so since the failure is systemic in terms of nodal or hematogenous spread or liver mets, so initiating chemotherapy early does make sense. The level 1 data will take a long time to come, because I mean, for a gallbladder cancer where we only have to provide data, to have a level 1 evidence on that will take a time. But now the whole world is moving towards that, and it is just a matter of time before this comes in. Without even a level 1 evidence. I mean, nobody asked for a level 1 evidence about patient falling from aeroplane with parachute or without parachute. So that way it will come in some time, but a lot of people are advocating or start adopted the practice of neoadjuvant for high risk gallbladder, which will be stage 3 and above.
So the question still remains unanswered, sir. Is at your center, are you routinely advocating neoadjuvant chemotherapy in such patients who are advanced T-stage or advanced nodal bladder?
All patients, without
all patients.
Yes.
Okay, so that clarifies the question's answer. So probably we are still category 2 people. Category 1 adopt the evidence first. Category 2 the second one, and category 3 after they have seen the success of the category 1 and 2 they adopt the evidence. Nikhil wanted to say something. You have to unmute yourself. Nikhil, you are not unmuted. Do you want me to continue with further?
Sorry, I'm so sorry. So except like if you look at the TMH criteria of neoadjuvant, most of them are unresectable to begin with. So these are the patients who are not mostly upfront resectable, and in these patients we definitely give neoadjuvant treatment. One thing which we still don't practice is only the nodal disease, right? So
Nikhil,
apart from that, we are.
So Nikhil, by giving neoadjuvant treatment, we are basically biologically selecting those patients who have a good biology. So it's the idea of the neoadjuvant treatment is not primarily to downstage the tumor, but to pick up those patients who are not going to fail distantly. And that's why you are not offering upfront surgery in such patients by taking care of the micrometastasis to start with. So right now, our, I think, aim in the neoadjuvant treatment is not downstaging, but improving the post-surgical outcomes. So though at our center, we have not still made consensus about the use of neoadjuvant therapy, but having heard from Mahesh sir and listening to his data, I think sooner than later, we are going to inculcate in our practice. These are 2-3 trials that had, these are not the most of the trials, but 2-3 trials which Dr. Mahesh sir has already shown in his presentation, which says that the outcomes are improved, but these are silent on the comparison of neoadjuvant chemotherapy versus chemoradiotherapy and the exact quantum of benefit between neoadjuvant chemotherapy versus the adjuvant chemotherapy. So this is a meta-analysis which was published in the European Journal of Surgical Oncology, and it's the latest one in 2019. And you can see, despite the neoadjuvant treatment, about 30% had a progressive disease. Clinical benefit response, which includes the partial response, stable disease, was at the maximum 66.6, and a partial response was to the tune of about 26%, only about 1/4 patients. 17% of the patients who responded to chemotherapy did not proceed to surgery, and the reasons are not well laid out why they did not proceed for surgery. Of all the patients, 50% patients were considered suitable for surgical resection, of which 10% further dropped out and 40% underwent curative resection. R0 rate for the whole cohort was 35.4%. Overall survival ranged from 1.5 years to almost about 4.5 years. And there was a difference of survival outcomes between the resected and the non-resected group. So based on this meta-analysis, the authors concluded that there is insufficient data to support the routine use of NACT or NACRT. So this has only benefited a third of whole cohort who eventually achieved a R0 section. So this conclusion makes me think that, are we really downstaging the tumor with the treatment? That's the intent. Or are we really decreasing the micrometastasis? But invariably, the answer should be a mix of both the things. When we are downstaging the tumor, we are also decreasing the risk of the micrometastasis. So till the time there is a phase 3 data, I think based on this data and based on our own TMS data, I think it will be prudent to use neoadjuvant chemotherapy in all patients with a heavy nodal burden or an advanced T-stage disease. Again, these are all meta-analysis and studies were retrospective by nature. and they included patients who survived to be on follow-up, and that's why they were included in the studies. So again, another study with this study was from Rajiv Gandhi Cancer Institute, and they said after the neoadjuvant chemotherapy, the median overall survival of the group that underwent a R0 resection was 42.8 months versus 6.6 months. So probably they selected a good biology patients with the neoadjuvant chemotherapy, which led to downstaging as well as eradication of the metastasis. Now, locally advanced or borderline resectable gallbladder cancer is a definition which is still evolving. So I would come back to Dr. Mahesh sir. So what are though you have already mentioned in your question answer about the locally advanced or borderline resectable, but for the better understanding of all our audience and especially the postgraduates, which particular cancers, gallbladder cancers, you think are locally advanced or borderline, which should be subjected to neoadjuvant therapy?
So, I mean, it was difficult for us to actually, when we thought about starting neoadjuvant therapy, we had to really think which patient to give. There had to be certain fixed criteria on which to base patients who should qualify to be given neoadjuvant chemotherapy. So I decided at that time, I mean, this was in 2012, we thought probably we can base it on something like BRPC, which had become by that time becoming popular at that time. So, and again, as Nikhil has also pointed about, whether all were local, really unresectable, locally advanced. So there were two groups of patients. One would be unresectable, locally advanced, non-metastatic. Other group would be resectable, locally advanced, which a surgeon would be tempted to operate, which can be operated also. I mean, even with periportal nodes or liver infiltration of 3 to 4 centimeter, a good surgeon would be able to take it out. So we needed to define criteria to define which patients actually to give chemotherapy. As you rightly pointed out, it's not about only downstaging or downsizing the tumor. It was more about initiating systemic therapy early to decrease the distant metastasis in the future and improving outcome. So that is why we took this T3, T4 stage. Liver part is still very dicey. I mean, there was nothing in literature to tell me at that point of time to tell me whether how many centimeter of liver would be locally advanced and how less than this would be a operable thing. So there was only one paper in historically which I could found where they mentioned about 2.5 centimeter, which was taken at that time as infiltration. So which is the only arbit thing actually in this, the amount of liver infiltration. A good surgeon would resect a 5 centimeter liver infiltration also. So then we also looked at the neoadjuvant part of it, that when we downsize. So if it was a 5 centimeter, the classical teaching is that you should probably resect the original tumor area. So if I was to downsize the 5 centimeter thing, that would mean much more bigger liver wedge or a hepatectomy in terms of 4B and 5. So that is how we decided these criteria. Important was to get in the concept of incidental gallbladder cancer, how to define incidental gallbladder cancer as locally advanced, because the patient will come with a very small disease in the GB fossa, which everybody will be tempted to remove at that point of time, or a node which is lighting up immediately after surgery after 4 to 6 weeks. So my thinking process was that if the disease has come up so quickly after doing a lab chole, mostly lab chole for incidental gallbladder cancer, it would mean only two things. One thing, either the disease was more than T2, so it was coming out of gallbladder and part of disease has been left behind, which would again make it T3 and above, or the disease has come back too fast within the 1 month of surgery. So if a node has appeared within a month, or a recurrence has come up within a gallbladder fossa within a month, it would show it as to be a disease with aggressive tumor biology, or an advanced stage disease which was missed on lab chole. So that's where we defined the LAGBC criteria for incidental gallbladder cancer.
So Dr. Abhishek, gallbladder cancer has 3-4 different type of lymphatic drainages. So do you literally have a watershed or cutoff of the nodal stations or the number of lymph nodes or the size of lymph nodes to exactly define that this patient I am going to operate and this patient I am not going to operate?
So we actually also strongly believe in neoadjuvant chemotherapy, and we routinely administer chemotherapy in all the patients. We have our own criteria, very similar to the TMH criteria, but we will take all node positive disease who have bulky regional lymph nodes, especially more than 2 centimeters in size. and then all patients with T4 disease and T3 disease with more than 3 centimeters of liver infiltration. We have also presented this criteria in 2016 at ASCO meeting and was published as an abstract there. And we are following these criteria since then. As far as nodes are concerned, even in our criteria, we follow N2 nodes like intra-aortic cavern or celiac lymph nodes or SMA nodes, which are positive. We also take these patients for a neoadjuvant approach rather than going towards a palliative therapy. And we are also analyzing our data of specifically these nodes were involved, like a preoperative intra-aortic lymph node positive, or preoperative celiac node for SMA node. Even these patients we are considering for neoadjuvant chemotherapy and then reassessment for surgery.
So that again reinforces the conclusion by Mahesh paper that chemotherapy with neoadjuvant intent in locally advanced or borderline resectable gallbladder cancer shows good response rate, and this results in curative surgical resection or disease stabilization in significant proportion of patients. And those patients who have a definitive surgery after favorable response has already been shown in multiple papers, even though we're retrospective, that they experience good survival versus those patients who either did not respond to chemotherapy or who were not able to undergo definitive surgery after a neoadjuvant treatment. So if you type in Google about the neoadjuvant treatment of the gallbladder cancers, there are lots and lots of screens that you can have with the multiple papers, retrospective reviews, meta-analysis, which again come back to the same point. Ultimately, you have to individualize based on the current evidence, and the current evidence is heavily tilting in favor of the neoadjuvant chemotherapy for all the advanced T-stage or end-stage disease or bulky disease for starting with the neoadjuvant chemotherapy. Now, to the surgeons in the group, what are the absolute contraindications to doing a resection in the gallbladder cancer? And this will be obviously followed by a question for the relative contraindications.
Dr. Pattnaik is there. I think he can answer. He can take up this.
Dr. Pattnaik? Dr. Pattnaik, sir? I cannot see him on my screen.
Okay, sir. I mean, any other, Dr. Abhishek, I think can take, or sir can take.
As far as absolute contraindications, for us, I think liver metastasis, peritoneal metastasis, or malignant ascites is definitely absolute contraindication. And even para-aortic nodes, if you see in literature, are definitely absolute contraindication. But we, after the advent of neoadjuvant chemotherapy protocols, now, as Mahesh described, if you found a para-aortic lymph node intraoperatively, there was no node on the imaging, and we found a node intraoperatively which is positive. And we also had a similar case, like node was negative and we did a radical resection, and then patient, finally the frozen section, final histopathology showed a positive node. Or intraoperatively, we had para-aortic nodes. We actually don't consider them as absolute contraindication, because we have analyzed our data and we will be publishing it soon. That with the advent of adjuvant therapy, even these patients can have earlier, mainly the data is from Japan, which earlier they showed that with para-aortic nodes, the survival is similar to peritoneal or liver metastasis. But the same group again published that data later, maybe recently in 2018, and they said these patients can have meaningful survival with the use of adjuvant chemotherapy. And we have similar data in pancreatic cancer also. So I think with the not obviously can be advocated as standard of care, but with para-aortic lymph nodes, unexpected para-aortic lymph node detecting during surgery, we go for palliative radical resection followed by adjuvant therapy. And if detected preoperatively, isolated para-aortic lymph node metastasis, we treat them with neoadjuvant therapy rather than considering absolute contraindication to section.
Okay, so you mean to say that even if it is a distant lymph node involvement, if it responds to either neoadjuvant chemotherapy or if you have an option of adjuvant chemotherapy, you will be more aggressive as a surgeon rather than labeling it as a palliative and leaving.
Yes, sir. But that is only for para-aortic, only for 16B, not for celiac. If you found a celiac node intraoperatively, definitely that goes for palliative therapy. We'll abandon the procedure.
I have a little bit of different view. So the Japanese paper was by Yamamoto, but he was alluding more to a station 13 node. So a pre-cable or a retropancreatic node is difficult to differentiate actually. So what he was showing in that paper, that taking out station 13 lymph node did help in survival. But as of now, we still consider, at least our group consider 16B para-aortic, pure para-aortic, especially on the left side of the aorta, as well as celiac and superior mesenteric artery as contraindication for absolute resection. Of course, as I said before, and Abhishek is also saying, probably sometime in future, as this concept of oligometastatic disease catches up or shows more data, we may change our practice at that point of time. But as of now, yes, that is a contraindication. But direct involvement of colon duodenum is not a contraindication. It's a contiguous organ which can be resected with the acceptable morbidity. So the direct involvement of contiguous organ is not a contraindication. Yes. Encasement of major vessel, yes, as of now, yes.
Okay.
Dr. Batra, Dr. Pattnaik has joined now. I think I could see him. So if you want to ask any question to him also.
So Dr. Pattnaik, I assume, is a surgeon.
Yeah.
Good evening, sir.
Yeah, good evening, Dr. Pattnaik. So, so before you joined in, we have discussed about locally advanced gallbladder cancers, the intent of the neoadjuvant treatment. So we're discussing about the absolute contraindications. And do you think there are some relative contraindications to gallbladder surgery, definitive gallbladder surgery? If a patient presents with jaundice, do you differentiate what type of jaundice it is and then decide whether the patient is going to be ever resectable or never resectable?
So, sir, hello.
Yes.
Can you repeat the question? Actually, there are lots of network issues. I'm inside the hospital only.
Okay.
Kindly repeat the question, sir.
So suppose a patient of gallbladder cancer presents to you with deep jaundice. Okay, so whether they are left as such on a palliative care, saying that these are the absolute contraindication for surgery, which is definitive treatment in such patients, or you think beyond jaundice to find out whether this patient is going to be ever resectable or never resectable with any upfront approach in the form of stenting or chemotherapy or some chemoradiotherapy or something like that?
No, sir. Actually, patients with gallbladder cancer with jaundice, actually, we mostly treat them as a hilar cholangiocarcinoma only. In terms of resectability, like apart from common hepatic artery involvement, main portal main involvement or any contiguous organ involvement, we don't rule out surgery. Obviously, before most of the patients, they need major resections. Mostly the most common being right modified extended kind of resection is needed. So before that, obviously, we try to just do a proper preoperative biliary drainage. We take here is 4 milligram per deciliter, the minimum bilirubin is required for liver resection for right-sided liver resections. So we normally do PTBD and then access the resectability. Apart from CHA, everything we take as a resectable. And we calculate FLR as well in Merian. And if the Merian is telling the volume is low, that is 30 to 35% we take, then we go for portal vein embolization.
So, so just to summarize the pre-operative diagnosis of a gallbladder cancer being treated, whenever there is a heavy nodal disease or an advanced T stage, then such patients should be subjected, which will be further reinforced by the future evidence, with the neoadjuvant therapy, chemotherapy preferably, to not only decrease the risk of distance recurrence as well as also to downstage the tumor to improve the surgical outcomes and thus improving the overall survival outcomes as well. Now coming to the next bigger chunk, the post-operative diagnosis. A diagnosis of gallbladder cancers made intraoperatively versus post-operatively by the pathology, which are the real incidental gallbladder carcinomas. Now, Mahesh sir already showed some slides about those patients who can be subjected to neoadjuvant therapy in such patients. I won't say neoadjuvant, but anterior chemotherapy or anterior therapy in such patients versus resection. So I know I am heavily tilted in my discussion with the surgeons, but because I know chemotherapy has got a definitive but limited role in gallbladder cancer, and surgery remains the mainstay of treatment if we have to give cure to these patients. So I will come back to Dr. Abhishek sir again. So incidentally diagnosed patients. Now there is a patient who has come up and or you have done a PET scan because patient presented 4 to 6 weeks after the last surgery. You have done a PET scan and it is showing some uptake in the gallbladder fossa along with a node in the suprapancreatic area or retropancreatic area. How are you going to proceed in such patients for the treatment? You offer them immediate surgery or you offer them some other treatments to start with?
if like as you said, the retropancreatic node is involved, then again it will, according to our criteria of neoadjuvant therapy, we will consider these patients for neoadjuvant therapy. We, as Mahesh sir also described, we believe that every time is a good time for resection, for re-resection in incidental gallbladder cancer, because that is the definitive staging procedure. But again, we selectively use neoadjuvant chemotherapy, as the case you described, when there's a residual lesion in the GB fossa as well as a positive node. And if, again, on the CT scan, it is, PET, as you said, the FDG avid lesion, we'll consider him for resection after neoadjuvant chemotherapy.
So that brings me to our medical oncology colleagues. Do you have a radiation oncology colleague also, Dr. Shefali, with us?
Yes.
Yes,
Dr.
yes.
Pooja is
I'm
there.
Dr. Pooja.
Dr. Pooja.
Yeah.
Okay, so Dr. Pooja, let's start with you. So what do you think in such patients in which there was an incidental diagnosis and the post-operative scan has shown some residual oblique recurrent disease at the gallbladder fossa site as well as some lymph nodes in the drainage area? Would you be comfortable advising chemoradiation therapy to such patients, or would you be believing more in the systemic chemotherapy in such patients?
So having a very limited experience, but I would still prefer to go for a neoadjuvant chemotherapy only, because I think giving a radiation would lead to a lot of post-surgical morbidity, post-radiation surgical morbidity. So at this point, with the experience and with the evidence what I can see, I think I would be more inclined to go for a neoadjuvant chemotherapy only.
Okay, so Dr. Sumant,
Sir,
what will be your choice of chemotherapy in such patients, as in with a neoadjuvant intent?
Sir, chemotherapy most commonly which we have been using is the gem-based, gem platinum-based chemotherapy. So GemCis is the standard of care, but most of us with the AIIMS experience have used oxaliplatin also. So my more personal experience have been GemOx. So,
but the Protege trial did not show any advantage of GemOx in the adjuvant setting.
Yeah, I know in the adjuvant setting, but GemCis, GemOx, most of the Dr. Atul Sharma's trials have shown a lot of favorable use with that.
But that will be in metastatic setting,
metastatic setting, yeah. In neoadjuvant setting, there have been a lot of data with the other subgroups. Pre-operative settings, people have recently there has been some data with the 5FU based settings, 5FU platinum based settings. So,
Dr. Atul, your choice of treatment in such patients?
Sir, I don't think I have used much in this setting. Mostly we discuss in an MDT meeting, and most of the patients, they land up in a re-surgery followed by adjuvant chemotherapy. But in case the question arises about chemotherapy, I would be keen for a triplet if patient is fit. GemCis and capecitabine.
GemCis and capecitabine. Dr. Atul,
Otherwise
you will be opening a Pandora's book if you say that.
So theoretically it is FOLFOX. But personally, I have not used.
I mean, I have never used. I mean, other than occasional one or two cases, I have not used it. But mostly it will be GemCis. It will be GemCis only. And I mean, as per discussion with other colleagues, people have used even trastuzumab also if it is positive. But this will be an occasional case.
So that will be occasional case, right? So idea is whether you or Sumant or me or Shefali, I think we will be more comfortable giving a combination of a platinum with the gemcitabine rather than going for a single drug, which could be gemcitabine or capecitabine, which is approved in the adjuvant therapy to some extent. But if we have to have response rates, then probably a combination of two drugs, which does not have a much compromise between the toxicity as well as the efficacy is advisable. Now, we're running short of time, but so these were the criterias which were basically used at MSK, and probably TMH also has similar criterias to decide which patients of incidentally diagnosed gallbladder cancer patients should be chosen for immediate surgery versus the chemotherapy followed by the surgery. So as Dr. Mahesh rightly pointed out, a T3, T4 disease, a node positive, someone asked a question in the chat box about the poorly differentiated. They are the candidates for neoadjuvant chemotherapy, and the choice of drugs we have already discussed. Now, again, if the patient does not have these all characteristics, then this patient qualifies for resection first. And Mahesh sir also told that there is no upper limit of the time we can wait. As soon as the patient comes to you and you have evaluated and don't find any high risk features, the patient becomes automatically eligible for a resection to improve this outcome of such patients. And obviously in such patients, based on the final histopathology characteristics, you have to use the adjuvant treatment as well. Now coming to the adjuvant therapy, now the tilt favors from surgeons to the radiation and the medical oncologists. Now, these are all the prognostic factors we are all aware about. The tumor invasion, that's a T3 stage, T stage, lymph node metastasis, preoperative CA 19.9 level, surgical margins, tumor grade, presence of LBI and TNI. So I would ask Dr. Pooja, do you think every patient of a resected gallbladder cancer requires a radiation therapy? The question is very pointed. The answer cannot be that pointed. So do you think every resected patient of a gallbladder cancer requires adjuvant radiotherapy? When I say radiotherapy, chemoradiotherapy.
So I think no, because in even Dr. Mahesh's slides, it was very clear that if you're talking about stage 3, probably the indication of radiation would be a positive margin. So that becomes a very clear indication. Otherwise, not every patient would fit into the criteria for adjuvant radiation. Of course, heavy nodal burden, then that also really fits into the adjuvant category. But in the stage 3A, I think it's positive margins only.
Okay, so basically the patterns of disease recurrence, though they say that locoregional as well as distant recurrences both are common, but locoregional recurrences happen more commonly in margin positive resections. There is a 20% rate of recurrences in the margin negative resections as well. And most of the time recurrences are systemic or distant nodal recurrences. That's why the trials and the data is more tilted in favor of adjuvant chemotherapy. And as you rightly said, margin positive tumors, they qualify for the chemoradiotherapy. We can have again a separate session or discussion on the sequences of chemotherapy versus chemoradiotherapy. But for the sake of time, we will continue this discussion further. So this is again the data which showed, again, retrospective data, operated patients, which showed what was the patterns of recurrence, and most of them came out that 60 to 80% were the systemic recurrences and 20 to 40%, which is though not a very small figure, a significant figure had a locoregional recurrences. But the analysis was, whenever there was a close margin or a positive margin, you have to re-emphasize the treatment with the local control much more than the distant control, because local control also helps you getting a distant control as well. Now, we have answered this question, chemoradiotherapy versus chemotherapy, the drug choices. So Dr. Sumant, any difference in the chemotherapy drugs in the adjuvant versus neoadjuvant treatment?
Sir, sorry?
So any difference in the adjuvant chemotherapy drugs? You have BILCAP data, you have PRODIGE data, you have GEMSIS data. So what will be your choice of drugs in the adjuvant chemotherapy of resected gallbladder cancer patients?
So my personal choice, as I said, will be something with a gem platinum based only in the chemotherapy. So that is the personal experience we have. So that is the limited experience I think we have in the adjuvant setting.
Dr. Sumant, you are in the north of India, which has got the highest cases. You can't say that you have a limited experience as far as chemotherapy of gallbladder cancer is concerned, especially when you have worked at AIIMS. I cannot buy that argument from your side.
So that is what we have been using, sir. I think that is the standard we have been using. I think a gem and platinum based combination. I think that is what the major training we have been using.
So you don't believe the BILCAP data?
So never used it. Never had a personal experience with that.
Okay. So you are saying you have never used it, right?
Yes, sir.
Okay. Have you read the BILCAP data, BILCAP trial?
So I've read the trial, but never, I have not had a personal experience with that. That's what I'm saying. That most of the time I've used a gem platinum based.
So
doublet.
Indirectly, I assume that you are saying that you do not believe in BILCAP data. If you have read that trial, which is giving a category 1 evidence for a drug in the biliary cancers, and still you are not using it, then probably you don't believe that data. Though even I am not a very firm believer of BILCAP, because if you see 10 years data, 450 patients only, and that too only about less than 20% patient has a gallbladder cancer. Even I will not be comfortable.
So I'll say that I personally will say that for gallbladder data, I think I will personally say that we should believe more of the Indian data than the Western data.
Right. So you have made a very valid point. So I will come to.
So does that, Dr. Batra, can I ask you a question?
No,
so
I am the only one who can ask the questions. Everyone else.
Dr. Batra has the right for question.
So okay, if you permit that one comment, so can we believe that some trial in the adjuvant setting for the first time showing OS benefit, why not to believe on it? So if a patient is
I'll come back
74,
to
75,
one more thing.
No, I will answer that question of Dr.
70
Shefali. Dr.
years old
Shefali,
patient, elderly
understand.
patient, why
No.
not bill cap?
Understand.
Okay.
Bill cap,
Yeah.
10 years, all prime institutions involved, and you get only 450 patients. And of those 450s, only 17-80% were gallbladder. So effectively, you do have a non-representative population. So you understand, even though, and third thing, it did not meet its endpoint. The primary endpoint was never met. So that makes... Yes, one.
One more point I want to make is, I think radiation still is a very underplayed thing in the gallbladder cancers. Most of us practice much more radiation than what is reported in the data.
Right, Sumant. Right. I would say that whenever there is a multidisciplinary discussion in our tumor boards, most of the time patients with advanced T3 or T4 stage and nodal burden or LVI or PNI or margins, they are going to get the adjuvant chemoradiation, and most of the time we sandwich that thing, even though there is no level 1 or 2 evidence for such things. So I think we had a very good discussion, and any question which was not answered or unanswered, or anyone who wishes to want to pose a question. Nikhil wants to ask a question, but that would be directed to Dr. Shefali only.
No, one question I'll ask.
Dr. Batra, I just want to play the devil's advocate here regarding neoadjuvant. So with a disclaimer that I'm in favor of neoadjuvant, but still with current set of data, I think Dr. Mahesh can better answer this question. Sir, do you think, like, can we still say it's standard of care, or we would say that data is still emerging?
I would say, I mean, given the current treatment practices in India, I would still say most of the surgeons in the north side especially are very aggressive in resecting gallbladder cancer. So I would say data is still emerging. We are having our phase 3 randomized trial of perioperative, which probably will help in answering that question. But if we really understand the cancer biology, the move is definitely towards instituting neoadjuvant chemotherapy for gallbladder cancer. But we still do not have a totally mature data to give a level 1 evidence that neoadjuvant chemotherapy should be used. So I would say it is an emerging data as of now.
Right, sir. Because only theoretical argument against that would be like we have started using neoadjuvant in many cancers, GI cancers I'm talking about, but there the response rate are pretty good. However, that is not the case in case of CHGBs, and all the data which we have, there is no comparison as such. So we have looked at the data, and we have understood that the patient who responded to chemotherapy and went on to receive resection did well, but we don't know what happened to the overall cohort.
So Nikhil, I think there are two types of gratification. One is immediate gratification and one is delayed. So response rate is something like immediate gratification. You are happy, the patient is happy, and you are happy that you have downstaged the tumor and your surgical results are going to be good. But overall survival doesn't wholly depend upon the resection. It depends upon the distant metastasis. And that only time is going to tell you. And that's what is called as a delayed gratification, that you get result in the form of overall survival. And if you see all the retrospective data, wherever the systemic therapy was used in the form of chemotherapy, all the cohorts uniformly showed that overall survival is better in those patients who received systemic chemotherapy and who underwent definitive surgery as well. So
Dr. Batra, I don't disagree with that. What I was just trying to take home point, because we had two surgeons who are from institutions who practice neoadjuvant therapy, and there was not another voice here. So I just wanted to represent that voice.
Okay.
That the jury is still out.
I will.
Can I ask one question, please, for the surgeons at least?
Yeah,
yes,
please,
ma'am.
Yeah. So when we are talking so much about neoadjuvant chemotherapy, if I give a case like, say, suppose it's a T3 N2, you have a node around, say, para-aortic or superior mesenteric, and you have given neoadjuvant chemotherapy 6 cycles, and patient has responded very well. After the chemotherapy, you don't see the node. The PET doesn't show uptake at the node. How do you proceed from here? Do you want to prove it by a US, or you straightforward go to surgery and resect?
So if the node has responded to chemotherapy, there is obviously it has to be a metastatic node to respond. A tuberculous node would not respond to a chemotherapy per se. So if you have to ask me, I would not go ahead and resect that if it was a para-aortic lymph node or a superior mesenteric artery or celiac lymph node. Probably put patient on a maintenance type of chemotherapy type of a thing is what I would do. That, but also now responding to Nikhil's last statement, only thing I would say, I can play from the other side also. So as you said, for other cancers, I mean, there is a definite role in other GI cancer for neoadjuvant, but if you really look at it, a lot of those neoadjuvant scenarios are now actually moving to adjuvant scenarios, especially even if you look at gastric cancer or colorectal cancers, or colon cancers also, not colon, but especially gastric cancer. From neoadjuvant to adjuvant is a major shift actually, which is occurring. And even in gallbladder, we don't know. We may probably move to a pure adjuvant setting also, or we may define gallbladder into a totally resectable, locally advanced, or a upfront unresectable, locally advanced, which will need neoadjuvant chemotherapy. So that's why it's still, the data is still emerging. We don't know.
So I thank all my panelists for their active participation, and hand it over back to Dr. Shefali and Dr. Nikhil.
Yeah, so thank you so much everyone for sparing your time. Wonderful discussion as usual, as always, and brainstorming session. Again, I thank you all for joining and giving your time. So Dr. Nikhil, the final comments, and then we close.
So nothing's left to say, and thank you very much, everyone. It was an excellent discussion, and every time I interact with such intellectuals, we always end up learning more, and it just shows us how less we know.
Sir, good evening.
Good evening,
sir,
good evening, Dr. Pattnaik.
Sorry, sir, for my disturbances. Actually, the network is not good, and I'm not in a very good range of network. So I just wanted to ask you, sir, one question, and Mahesh sir is also there, so it is an opportunity for me to ask this question. So, because here, sir, in Bhubaneshwar, being a tier 2 cities, a lot of private nursing homes and all kinds of hospitals are there. So we do get a lot of patients after doing partial cholecystectomy. They say it is because of acute cholecystitis. And over last 2 years in AIIMS Bhubaneshwar, we have got 2 patients who has been reported as T1A of that partial cholecystectomy specimen. And we do a CT, and then we see there is a sizable amount of gallbladder left, but the margins they report as free. We review the whole. If one patient, we could get the whole of gross specimen which we reviewed at AIIMS Bhubaneshwar, and the margins were free. The rest we could not get the whole specimen. So how to proceed, sir? Because if it is a total cholecystectomy, well, we may observe if it is a carcinoma in situ or T1A, and there are no notes on CT. But if it is T1B and the area is in fundus and half of the gallbladder is left, and they are telling the margin is negative, then how to proceed from here? They are really very tricky situations, and I just want your opinion on this.
It is a tricky situation actually. So any other scenario, probably incomplete surgery would warrant a completion surgery. So even if it is only if it is T1A, one thing is T1A is a diagnosis which has to be very carefully made. A lot of time it may not be actually T1A, but probably T1A where you have removed the tumor in the fundus, and you just left behind a part of a gallbladder as subtotal, but that scenario would be very difficult. Probably you are dealing with a situation where you have chronic cholecystitis or xantho with a small focus of tumor in this. So there probably you can observe, but anything other than that would need revision surgery 100% for sure, and neoadjuvant or adjuvant chemotherapy based on what we get finally.
Thank you, sir. Nikhil, sir, your opinion?
Same. I mean, nothing to add there. So I guess with this, we can conclude this session. Thank you very much, all the esteemed colleagues and the audience to join us. And next time we will be discussing surgery for gallbladder cancer. So that is going to be a surgical topic. and we will discuss approaches, techniques, and all those kind of things. So thank you very much. Good night.
Good
Thank
night.
you, Sachin.